Good morning. Thank you for the opportunity to present to you. I'm going to tell you today about a technology that has been around for 14 years. We have been prescribing antibiotics into the human body for over 70 years, ever since penicillin was discovered during World War II. But we give those antibiotics into the human body in a systemic fashion, whether it's orally or intravenously. And we use very high doses. And my question to all of you is, do you think this is the most effective way of delivering antibiotics, or the smartest way of delivering antibiotics into the human body? The TP.HCM technology, what we're trying to do is be more intelligent on how we give these antibiotics. The technology per se is a fully absorbable polymer that allows us to put the antibiotic exactly where you need it, when you need it, without having to go systemically. And we end up using a lot less antibiotics because we put it. So when you think of TP.HCM, the name comes from tyrosine, which is the fully absorbable polymer we use, and RX for therapy, which is two antibiotics that we have put, minocycline and rifampicin. Now remember that what we're trying to do is a polymer control elution. The beauty here is after implanting TP.HCM within 2 hours, you're going to have enough antibiotic in the pocket, but you're able to sustain that concentration of antibiotic a minimum of 7 days. I'm going to explain why we chose these two antibiotics, and then between 4 to 9 weeks, everything goes away and you're not left with anything behind. Now, there's two reasons why you want to keep this technology in mind. Our main indication is for stabilization of your cardiac or neurological device. And the best word in English to remember what type of patients can benefit from this technology is the word TIME. T for Twitler syndrome, I for infection prevention, M for migration, and E for erosion. Now, our secondary indication, like I said, is infection prevention. Let's talk about the first indication, which is for stabilization. Every time we put a device into the human body knows it is a foreign object, and it will start to encapsulate that device. But that capsule could take between 1 to 2 months to fully complete. With the TP.HCM technology, you're going to jumpstart that process, and you can see that after 1 day of implant, you can see that the tissue starts adhering to the mesh. But look at what happens at 7 days. You already have a fully formed capsule around that device, and this is what helps the device from migrating, eroding, or patients will be more difficult to be able to Twitler. And then after 4 to 9 weeks, everything goes away. Now, the majority of the doctors worldwide are using this because of the anti-infective properties. And you can see here it all starts with a stitch abscess that may develop into a pocket infection that could lead to risk of endocarditis, and then you have significant morbidity and mortality when these patients get infected. The good news is that infections do not occur often. Why do I say this is the good news? Because between 96 to 99% of the time, we are doing a fantastic job in the implantation of these devices. This 1 to 4% is when we looked at total patients that have been implanted. When we looked at high risk patients, that 1 to 4 becomes 3 to 5%. But the problem is, if you end up being one of the patients that brings certain risk factors to your operating room, you can end up in this group. Not only affects morbidity, but it also affects your mortality, and I'm going to tell you a little bit more about this. Also, the cost of these infections to the healthcare system is quite expensive. Now, we always give 1 dose of prophylactic antibiotic prior to implanting these devices. And the guidelines say that we use, 90% of the time we use an antibiotic called cefazolin. It's a cephalosporin. And we use this because of this study down here by Dr. De Oliveira, who was a Brazilian doctor who did a randomized control trial. Half the patients received 1 dose of cefazolin, the other patients received nothing. This trial was stopped early because halfway through the trial, the benefit of giving only one single dose of cefazolin reduce infection, but it also reduces mortality. And based on that alone, this is the reason why we give a prophylactic antibiotic. Now, if I told you that the antibiotic that we use 90% of the time, which is cefazolin, does not cover, I will repeat it does not cover 70% of the bacteria that are going to cause these infections in the pocket. So the question that we need to be asking ourselves, how much of that intravenous antibiotic we're injecting actually gets to the pocket where you need to also protect? And if some gets there, how do we know it's in therapeutic levels? And unfortunately, very little antibiotic gets there, and it is definitely not in a therapeutic level. Now, because of this, doctors have been trying to do two things for years. One is irrigating the pocket with antibiotics or putting patients on additional antibiotic post-procedure. We know that neither one of these two things work because you don't get to a minimum concentration and sustain it. So the director asked the patient, did the hospital staff did this to you? Referring to nurses and doctors. And the patient says, no, the hospital staff. But the patient is wrong because it is not the hospital staff, it's his own staff. Because these bacteria live on the skin. They live on your skin, they live on my skin. We can try to eradicate these bacteria from the skin, but we will not be able to. What we can temporarily do is sanitize the skin and allow us to have enough time to make an incision, do what we need to do, close it up, and prevent these bacteria from coming in. Again, these bacteria, 43% of these infections are done because of your coagulant negative staph or staph epidermidis, 26% by your staph aureus family, and about 8% by your gram-negative rods. So let's understand why this happens. Every time we make an incision into the human body, there's always opportunity these bacteria could enter the body. This is the skin. These are the bacteria that live on the skin. You can try to betadine, iodine, put alcohol. Again, you will not be able to eradicate the bacteria from the skin. So the bad news is when these bacteria get in, they love to colonize. And after they colonize, they build what we know to be biofilm. And biofilm is nothing more or nothing less than how they protect themselves. You can call it their roof, their shield, their umbrella. If that biofilm breaks, this is what sets up the possibility of a cascade of an infection. Now, think about this. Between 32% to 44% of patients, when you come back for a replacement, will be having colony on that pocket. Now, a colonization does not mean an infection. It just seems, it means that they're living there in that pocket alone, and if you don't bother them, they're not going to bother you. But what happens when the device runs out of battery and now you take that battery out and you put one in? If you are one of those 33 or 32 to 44% of patients who are colonized, this is where we tend to get into trouble. Now, why do we choose these two antibiotics? For three reasons. Number one, you can see that minocycline and rifampin cover the majority of the bacteria that are going to cause these infections. Cefazolin, like I said already, this bacteria alone is responsible for 43% of these infections and is not covered. There's other agents that are better, like vancomycin, at covering these bacteria, but the challenge with vancomycin is that it has one of the largest molecular structures of any antibiotic. So it does not penetrate a vascular tissue very well. And the area where we're implanting these devices is pretty much avascular. Also, the other challenge with vancomycin is once you have biofilm formation, because of the large molecular structure, it cannot penetrate biofilm. The second reason why we chose this antibiotic combination is because they work as a team. The top one, minocycline, is bacteriostatic. The below one, rifampin, is bactericidal. So in combination, they work very well. One kills the bacteria, the other one prevents the bacteria from continuing to reproduce. And the third reason is there's 5 randomized controlled trials that show the efficacy of this combination. Now, what do we do as a technology? Like I said earlier, we have the ability to help with stabilization for migration. in your heavyset patients that may tend to have a lot of fatty tissue, or females with larger breasts, erosion in your very elderly thin-skinned patient. But the most important thing we do now, and if you remember anything from everything I'm telling you today, the bullet in blue is what matters here. Within 2 hours, we are going to reach a minimum inhibitory concentration, but you're able to sustain that concentration a minimum of 7 days. And this is how it's depicted here. You put Tyrix, you get to that concentration, and you sustain it. All of us have taken antibiotic in our lifetime, and the very first thing the doctor tells you to do is, if I give you a prescription for 7 days, make sure you complete that dose for 7 days, because if you stop taking it, you allow that bacteria to become resistant. And now, we had 7 studies that have shown efficacy of this technology in reducing infections between 70 to 99.9. But none of those trials were randomized control. Then we embarked into a trial called the RAPID trial, which was a 7,000 global trial. They wanted to look at the efficacy of this technology in treating not only pocket infections, but major infections. It's important to understand which patients were allowed into the trial and which patients were excluded. A high-risk patient was defined as any generator, replacement, revision, of upgrade of a pacemaker, CRTP, ICD, or CRTD. Which patients were left out? Patients that were de novo pacemakers and de novo ICDs, or patients that were at the highest risk, patients on hemodialysis, patients that were taking more than 20 milligrams of prednisone, or patients who had previous infection within the 12 months. Why did they leave these patients out? If these patients are the ones that benefit the most from this technology, the investigators wanted to control the variables, the ones that don't get infected, the ones that get infected a lot. And they were able to show a 40% reduction in infection of major infections and 61% reduction in pocket infections. So you can see here it's very hard to be able to show a p-value when you start with a control group so low, but a p-value was shown. The safety, there's no difference between if you use Tyrix or didn't use Tyrix. We also have data now to 3 years, and in 3 years, the advantage of this technology continues to hold. But this is the second most important slide. Why do I travel the world teaching this technology? Because if you end up with an infection, your mortality will more than triple at 1 year. This is the mortality from the RAPID trial with no infection. It's around 5% at 1 year, but that jumps to 16% at 1 year if you end up with an infection of your cardiac implantable device. Now, let's look at the bacteria that were colonized. You can see that in the control group were 19 infections and only 4 in the envelope. This had a p-value, statistically significant, and this is why we saw the results that we saw. The only important thing here, and that worries us a lot besides infection, is hematomas. And we know there's a strict correlation between a hematoma and that hematoma converting to an infection. And in the trial, we were able to show an 82% reduction if you have Tyrix in a hematoma, meaning that hematoma did not convert to an infection. Now, where should we be using these patients? This is for high-risk patients. And these are the factors that have been identified in the literature. It's divided in 3: procedure, medications, or characteristic. The number one predictor that you could end up with an infection is early reintervention. You have 15 times the likelihood patients could end up with an infection. Patients on steroids are immunocompromised, or patients in dialysis renal failure. What did we learn from the RAPID trial? Any replacement, revision, of upgrade, and CRTD de novo benefit, as well as your dialysis, immunosuppressive agents, and infections. I'm going to bypass, and I'm going to talk about a trial that was just recently published this year. It's an Italian trial of 11 hospitals. Close to 1,800 patients were diagnosed, and here we have data now to 5 years as to the benefit of this technology. You can see that at 5 years, the infection rate for Tyrix was 2.1, and the no Tyrix was 8.1, all statistically significant. Now, not only is this being accredited by the American Heart Association as a prevention method, besides adhering to standard infections single-dose antibiotic, TAREX is recommended, and we also have now a consensus statement that is backed up by 5 societies, including Asian Pacific HRS, and the TAREX technology has a green heart as to you is recommended, indicated, and you should be doing this.
Like, subscribe button ya.